our thanks to OrthoTV for their continued support in making this session accessible to global audience. Today's theme, degenerative cervical myelopathy, past, present, future, is both timely and relevant. As many of you are aware, degenerative cervical myelopathy is the leading cause of spinal cord dysfunction in adults worldwide. Yet its pathogenesis and treatment strategy remain incompletely understood. Over the past decade, however, significant strides have been made in understanding its pathophysiology, diagnosis, and treatment strategy. So today's webinar brings together leading voices from across the Asia-Pacific region to explore how we have arrived at our current understanding of DCM and where we are heading. Regarding program overview, I would now like to share a brief overview of today's program. We invited 6 experts, but unfortunately, Dr. Yu Sun from China is unable to join us today. So we remove case presentation 1. So the program is consisted of 5 talks. So we begin with a keynote by Professor Kawaguchi, who will guide us through the historical evolution of DCM treatment. Following this, Professor Gabriel Liu will address the current surgical controversies, discussing the metrics of anterior, posterior, and hybrid strategies. Then we'll hear from the Professor Rishi, Kanna, who will share insights into future of DCM treatment. And for the case discussion, we are grateful to Professor Jin Sup Yeom for presenting on complex upper cervical pathology, and Dr. Dong-Ho Lee, who will conclude with a live surgical video presentation on vertebral body sliding osteotomy for K-line negative OPLL. And following each presentation, we will have a discussion moderated by our expert moderators, Professor Shrivastava and Professor J.B. Park. So I now hand over the session to our moderators to proceed with the scientific program. So please, the moderators.
Yeah, thank you, Dr. Takahashi, for nice introduction to this webinar. Yeah, I'd like to invite first speaker, Professor Yoshiharu Kawaguchi from Japan. He will talk about historical evolution of DCM treatment, lessons from the past. Yoshi, please.
Thank you. Can you see my slide?
Yes.
Yes.
Okay. I will talk. Okay. Hello, my name is Yoshi Kawaguchi. I'm from Toyama, Japan. It is great honor for me to talk today on the APSS web course. So I will talk about lecture 1, historical evolution of DCM treatment, lessons from the past. This is my CV. I was the Orthopaedic Education Chairman of AOSPINE Asia Pacific region. Okay, DCM, degenerative cervical myelopathy, has 2 meanings. CSM, cervical spondylotic myelopathy, and OPLL, ossification of the posterior longitudinal ligament. Japanese Orthopaedic Association, JOA, has published clinical practical guideline on the management of CSM. And also, JOA has published clinical practical guideline on the management of OPLL. Today, I will mainly focus on CSM. CSM is a general term for the disease causing paralysis owing to spinal cord compression as a result of narrowing of the cervical spinal canal and age-related changes in the cervical spine combined with instability and trauma. This is a diagnostic algorithm for CSM. Firstly, we check the clinical symptoms such as numbness, clamminess of hand, gait impairment, and bladder disturbance. Then we check the signs such as deep tendon reflex and pathological reflex and presence of myelopathy hand. Then image diagnosis is carried out using X-ray, CT, CT myogram, and MRI. We check the consistency between the level of the responsible spinal cord lesion inferred from symptoms and signs and the site of compression on image. Then we confirm the diagnosis of CSM. I believe this process is very important because we do not treat the image findings. We must treat the patient complaint. As for the therapeutic algorithm, if patients have mild and non-progressive myelopathy, conservative treatment should be selected. Surgical treatment should be considered in the cases with severe or progressive myelopathy. However, the guidelines said that conservative treatment is weakly recommended in mild to moderate CSM cases. Apparatus aimed at resting the neck using color, traction, and lifestyle guidance. Pharmacotherapy using anti-inflammatory analgesics, vitamin B12, muscle relaxant, anti-inflammatory, anti-anxiety drugs, prostaglandin, preparations, steroid are usually taken. Thus, we mostly take surgical treatment. Surgical treatment has two options: anterior decompression surgery, ADS, and posterior decompression surgery, PDS. ACDF, anterior cervical dissection and fusion. ACCF, anterior cervical colectomy and fusion, and ADR, artificial disc replacement. These are indicated usually 1 or 2 levels cord compression cases. Regarding PDS, laminectomy, laminoplasty, and posterior spinal fusion are performed. Indication is that for the patients with more than 3 levels cord compression or developmental narrow spinal canal. Anterior decompression surgery was developed in 1958. This method was used for cervical disc herniation by Smith and Robinson. In the same year, Clover utilized similar method for ruptured cervical disc. To date, there are two types of anterior decompression surgery: anterior decompression with fusion, fixation, interbody approach, and Williams-Isu method, colpectomy, and without fixation, keyhole foraminotomy, transuncal approach, transvertebral approach, partial colpectomy. Since then, there are numerous devices have been developed. This slide shows a variety list of anterior cervical cages. This is a list of anterior cervical plates. Nowadays, it is very popular to use these devices in anterior cervical surgery. But the purpose is to achieve bony fusion. Artificial disc replacement is performed to preserve the cervical motion. However, efficacy in the long-term follow-up is still controversial. As for history of posterior decompression surgery, cervical laminoplasty, cervical laminectomy was used in most of the cases until 1970s. However, there are lots of problems, such as post-operative segmental instability, post-operative kyphosis, perineural adhesions, and late neurological deterioration. Thus, cervical laminoplasty was developed in 1972. There are various kinds of cervical laminoplasty until now, showing in this slide. Cervical laminoplasty is divided into two types: open door type, which is one hinge type, and double door type. In addition, Schleich's muscle preservation technique is categorized in minimum invasive surgery for paravertebral muscle. Our method is open door type, named unblocked laminoplasty, which was developed in a hospital in 1981. We use this method still now. This is intraoperative view. We used to use spinous process to keep rotated lamina. We now use HA block instead of spinous process. We report the result of more than 20 years. Long-term results were satisfactory. However, some patients has post-operative kyphosis in the long term after laminoplasty, shown in this slide. We notice the patient with local kyphosis exceeding 30 degrees had poor post-operative outcome, and these patients require anterior decompression or collection of kyphosis in addition to posterior decompression. This is a case of 60-year-old male who had cervical myelopathy due to OPLL. He had lordokyphotic cervical alignment. His MRI showed spinal cord compression at C34 and C56 levels. CT reveals small OPLL at C56 lesion. We perform posterior decompression and fusion using pedicle screw fixation. Post-operative CT found pedicle screws were nicely inserted. Post-operative cervical alignment became straight from kypholordotic alignment. Post-operative MRI showed that the decompression was nicely achieved in this case. Regarding the surgical outcome, the guidelines said that in the surgical treatment of cervical spondylotic myopathy, which is more useful, anti-decompression and fusion, ADF, or laminoplasty? The statement, the answer is, there is no clear recommendation. In addition, in surgical treatment of cervical spondylotic myopathy, which one is more useful? Anti-decompression fusion, ADF, or posterior decompression fusion, PDF? There is no clear recommendation. And also, additional fusion useful for cervical spinal myopathy compared with posterior decompression alone? The statement is, it is difficult to provide a clear recommendation. Therefore, we must say the evidence is lacking for the surgical treatment. We will summarize the issue for the treatment of DCM and future improvement. Issues: seek the useful conservative treatment, decide the surgical indication, and select the proper surgical method, although the scientific evidence is lacking. Future improvement: improved imaging, DTI, functional MRI for early detection of cervical myopathy, neuroprotective therapies to prevent spinal cord damage, and better risk stratification models for treatment decisions. Thank you very much for your attention.
Yeah, thank you, Dr. Yoshi, for nice talk. Yeah, any questions from the audience? Yeah, if the audience have a question, please, yeah, type your question at the chat box. Okay, still there is no question from the audience, so I'd like to ask the one question for Yoshi. Yeah.
Yep.
Yeah, for the anterior surgical option for DCM surgery, how do you decide the anterior cervical circumference fusion and cervical disc arthroplasty for the DCM patients?
Orthoplasty or fusion? You ask. Yeah. I think I indicate the young cases which required cervical motion in future. So I will choose artificial disc replacement in this case. However, more than 60s and 70s, I think cervical fusion has no problem. So I will choose cervical fusion in these cases.
Okay, thank you. Also, second question is that sometimes we can see the disconnect between imaging severity and clinical symptoms in myelopathy patients because imaging shows severe spinal cord compression in asymptomatic or minimal symptoms. Also, minimal cord compression findings in patients with severe myelopathy patients. So for this kind of cases, how do you decide your management option for the myelopathy patients?
Thank you very much. That is a very, very important point. I will usually tell the patient in the fact. So I explain you have spinal cord compression, but now you do not have any symptoms. But if you have some numbness or clumsiness, you feel. So please come to my hospital as soon as possible. And I will check your neurological examination. And at the time, I will strongly recommend the operation. So I do not do the operate the patient without any symptom. However, we must check the his progression of the symptoms and neurological finding. That is a very important point, I think.
So yeah, do you usually recommend the prophylactic surgery for the minimal symptom with the severe spinal canal stenosis? How do you do?
Yeah, I usually do not do the prophylactic surgery for the patient. However, if patient hope to have the surgery, maybe I will do with the explanation, very severe, very precise explanation to them.
Dr. Rishi, Dr. Rishi.
Okay, yeah. Any questions from the faculty?
Yes, I have a question to Professor Yoshi. Thanks for the wonderful presentation. You told for two-level disc prolapses, two-level compression, we generally prefer an anterior surgery. But sometimes we see patients with a skipped normal level in between. So like a C3-4 cord compression and a 5-6 or a 6-7 cord compression. So in that situation, do you do still two-level anterior surgery with an in-between normal level, or do you do a posterior procedure?
I will do the posterior procedure in this case. That is our strategy. However, we will do 3 levels anterior decompression and fusion. And yeah, it depends on the patient condition and the image findings. But more than 3 levels, I will prefer to the posterior decompression.
Thank you.
Yeah,
Thank you very much.
Yoshi, yeah, you demonstrate the wonderful posterior CPS laminoplasty and CPS fixation for the cases. But the main symptom is C5, 6, 7, but also C3 for show the cord compression. Why do you laminoplasty for C3 to 7, but the fixation from C4 to 7? You did not insert the screw at C3. Why?
Okay.
Yeah, thank you very much. Yeah, in that case, the upper segment, I mean the C3 to 5 is lordotic alignment. So the lower segment is kyphotic alignment. That's why I think it's better to choose from C4 to C7 collection. So C3 to 4 do not have to be collected.
Oh, really? Yeah. Is there any risk of AST problem after long-term follow? Is there any risk of AST problem after long-term follow? Because CPS is very strong fixation.
I don't think so, because we performed C3 to 7 laminoplasty in this case. So I do not worry about that.
Okay, thank you. Thank you, Yoshi. Yeah, thank you, Yoshi. Nice to let's move
Can
on to second.
So I think you rightly mentioned sometimes it is difficult to convince the patient for the surgery as he has mild symptoms. But nowadays this DTI is a very good tool where you have to take the sequential DTI every 3 to 6 months you take, and that shows the change in the value. Okay, ADC value, FFA value, FA value, and ADC value, it changes, and it comes in the colored form. So you should be able to convince the patient, more so if single level has mild instability. So those cases are prone to go for fully developed myelopathic signs also. So I think these 2-3 points one can convince the patient that this your case is a risky case. You have instability at one level, and your DTI findings are changing, and it is a gradual change. So I think these are the 2 points which are important for explaining to the patient. Thank you.
Thank you, Sylvester. I really agree with your opinion. That's why I told the future perspective, including DTI. But DTI is not usually used in the clinical setting. So maybe in future, DTI is more important tool to diagnose cervical myelopathy. Yeah, and today I did not mention about the motion of the cervical spine. I think it is very important for the cause of the cervical myelopathy. Thank you very much.
Thanks.
Okay, okay, Dr. Sudi. Yeah, what do you think about the electrophysical studies such as SSEP and MEP to investigate mild myelopathy symptoms?
Yeah.
With severe Kanna stenosis. Also, do you think that it is?
Yeah, actually, it is important. And again, the same way it works. You have to have the sequential. Suppose in January you have taken, these electromyographic study, and again you are again taking into August, means after a gap of few months, and you find that there is a changing, pattern. In that case, this is also one of the two. And moreover, when patient deteriorates science-wise, maybe symptoms are not that much, and that is the reason patient refuses surgery. In that case, you will start seeing that patient is now going towards the myelopathic hand. The first web space is getting empty. He is having signs like clonus, exaggerated reflex, but still he is able to manage it. So these are the strong point which should be mentioned on the paper. And I think that is very important for further follow-up the patient.
Okay, thank you, Dr. Steve, for your valuable comments for the audience. Any questions from the faculty or audience? If there are no further questions, let's move on to second talk. Second speaker. Thank you, Dr. Yoshi. Second speaker is Dr. Gabriel Liu from Singapore. He will talk about current surgical controversy in DCM, anterior versus posterior versus hybrid approaches.
Thank you very much.
Gabriel, please.
Thank you very much, Professor Park, and it's wonderful. Thank you, Chairman, for the kind invite. And can everybody see my slides?
Yes, yes.
Okay, great, wonderful. The topic is given to me is to talk about the current surgical controversy of the DCM anterior versus posterior versus hybrid. And I understand the ticket. Maybe we will just spend some time determine the factors that actually governize when to do anterior and when to do posterior and the interpretation of what is hybrid. As previously mentioned before, cervical myelopathy is really the most common spinal cord lesion that has been seen for people older than 55 years old. And unlike radiculopathy, and then myelopathy will progress, and as a result, the treatment is really recommend surgical intervention to a certain extent. Previously, we mentioned by Professor Yoshi, talk about the mild group of myelopathy symptom. As you all know, Michael Failings under the AO Spine group have joined common consensus in 2017, recommended if the DCM between the MJOA score between 0 to 11 strongly recommend surgery, whereas the MJOA score between 12 to 11, 14, then you recommend surgery. For those who are mild, at least the recommendation for their consensus is that at least offer surgery. But if the patient choose not to do the surgery because they are minimal symptom, then you need to offer frequent observation for them. As currently, the principle of cervical myelopathy treatment is anterior approach, where you directly remove the things that is pressing on the cord to remove it, or indirect approach, where you open up the posterior lamina to allow the spinal cord to move backwards away from the anterior lesion, causing the compression or the spinal cord to expand. As you already mentioned by Professor Yoshi, there is various different anterior topic search option that can actually do, but the complication can grossly divided into the approach related, which is particularly we all worry about dysphagia, dysphonia, airway obstruction, and sometimes loss of motion to a certain extent, or graft related, such as pseudoarthrosis, implant failure, and so on. Even though if you mention do the fusion surgery well, then the adjacent level deterioration described by Alan Hillenbrand, which is well quoted, is about 3% per year and 25% per 10 years, yet you need a second surgery, and leading to the development of the artificial disc replacement. Posterior surgery, as mentioned before, we have various different choices that have already been mentioned previously in the previous talk, and then these are some of them. While it is my preference, if it's posterior surgery, whenever we can preserve motion, we will preserve motion. But complication using motion-preserving lameloplasty may have problem. Classically, it's famous for axial neck pain up to 60%, gradual loss of range of motion, kyphosis, or the famous C5 palsy that everybody talks about in every single conference. And of course, there might be some implant-related problem. So how do we look at what are the factors that actually galvanize the anterior versus posterior approach? Well, in 1985, Professor Yorinobu started the concept of the comparison between anterior surgery more than 3 level versus a posterior surgery more than 3 level for cervical myelopathy. And his conclusion is that while the anterior and posterior surgery have a good recovery of the myelopathy problems, posterior surgery have much less complication when that compared to anterior surgery. That leads to a whole movement of development of the posterior surgery from multiple 3 or 4 level and above, called compression for posterior approach. Subsequently, systematic review, meta-analysis have substantiated some of these ideas that it is true for this matter. Another problem that one needs to think about is the type of pathology. As previous speaker talks about, if it is an OPLL, then do you really want to do an anterior multiple corpectomy C2, 3, 4 in this particular patient in this area? And also, if there's a double layer sign has already been shown, which suggested that OPLL has already penetrated inside the dura, and therefore anterior approach will definitely leading to a CSF leak. We perform some of the smaller surgery to looking at a particular type of OPLL causes complication, looking at 131 patients. And basically, we talk about that patient who basically have a peak type of OPLL and a kyphotic spine have up to about 3 or 4 times higher rate of complication when we deal with it. So the pathology is another important factor. The amount of compression, I think, is another important factor to determine anterior and posterior surgery. If the space occupying ratio as shown in here, B over A, and it is less than 60%, then meta-analysis has demonstrated that it doesn't really matter whether you do anterior or posterior approach, the outcome is similar. But if the cord compression ratio or space occupying ratio more than 60%, then direct removal of the pathology from anterior would actually give you a longer, better outcome for long term. So, but at the expense of higher anterior complication rate. So what are the cases that is suitable for posterior, multiple level posterior surgery? We all know because of the dorsal cord migration, we need to have a good lordosis. But to what extent to this? Well, basically Chris Shaffrey and then Thomas Buer, and then identified the patient, if you have after the removal of the anterior compression, and then if you correct the kyphosis, the patient do better for those compared to people who do not correct the kyphotic deformity in terms of the kyphosis. This is one of the reasons why there's a concept of stretched cervical spondylotic myelopathy. When the neck is bent forward, the spinal cord is being stretched more than 2 to 3 centimeters. This might lead to the axonal deterioration of the spinal cord. And even though if the cord doesn't look like it's compressed a lot from the structure, but the fact that it's being stretched, myelopathy may still occur, and the correction of the deformity is important. Most of us will use the concept of K-line to determine anterior versus posterior surgery, which is the line drawn from the center of C2 to the center of C7. If the lesion is anterior to the K-line, is a K-line positive lesion. Therefore, motion-preserving lameloplasty will work. Whereas if the lesion is posterior to the K-line, therefore anterior surgery tends to do better. Or in an elderly patient, you don't want to do multiple anterior surgery, one will consider posterior surgery decompression with fusion method for that. In the last 10 years, ISSG helps us to understand the cervical deformity added to the third dimension to the cervical myelopathy. They talk about the C2, C7 plumb line, SVA, which is the line drawn from the center of the C2 from the posterior superior aspect of C7. If that distance is more than 4 centimeters, the patient is associated with poor clinical outcome. And similarly, if it is the C1 tilt, which is the line from the superior ampli of T1 to the horizontal, is more than 40 centimeters, 40 degrees, then the patient is associated with poor clinical outcome. Professor Yun from Shanghai have proven the C2, C7 SVA, if it increase together with increased age, the patient tends to develop myelopathy more and have a poor myelopathy outcome using this concept. Similarly, Sakai from Japan and talk about if the C2, C7 SVA almost like that is more than 4 centimeters, then laminoplasty would not work. Anterior surgery is recommended in this group of patients. Similarly, Raoul talks about if the T1 slope compared to the cervical lordosis, the mismatch is more than 20 degrees. Again, posterior laminoplasty may not work and anterior surgery might be better. So far, we have been talking about the regional cervical alignment problem. How about the global sagittal alignment problem affecting the cervical myelopathy, particularly C7 plumb line, which is a line drawn from C7 to the line anterior to the sacrum. Go Yoshida have reminded us if the C7 plumb line is more than 5 centimeters. If you look at the picture below, even though you have a good cervical lordosis with a C7 plumb line more than 7, then the posterior decompression laminoplasty may not be sufficient. And as a result of that, they recommended if the C7 plumb line is more than 5 centimeters, if the cervical pathology is less than 3 levels, then you do anterior surgery. Whereas if it's more than 4 or 5 levels, they recommend a posterior decompression and fusion as well to try to improve on the alignment, on the stability. Finally, do you really want to do a 4-level anterior surgery in this particular neck? And how about, does the patient have any say in all this surgery? What if the patient is a taxi driver, they need to turn the neck to drive in order to work, and then if you do a multiple fusion surgery, and then the patient may not work. So this is a case of a 35-year-old male with C6 myeloradiculopathy. And then you can see that the patient have a compression at C5-6, a little bit touching of the cord at C4-5. Many of us will therefore do ADR for the C5-6 in order to delay the deterioration of C4-5, in order to help this young active person. And then the indication for ADR is really quite straight, governed by the FDA IDE trial with a list, which you can easily accessible from the internet. While it is a good result for 1 to 2 level, and one has to remember, and then long-term follow-up may still have its problem. So for example, these similar cases after 8 years start to have radicular pain and myelopathy again. And you can see that the posterior syndesmal fiber is start to join behind the disc space, and the foraminal stenosis is returning back as well. So the artificial disc replacement may not be this overall the all-and-all solution to this group of problems, but close follow-up is important. And in this case, we did a laminectomy and a fusion with foraminotomy after that. And some cases, actually, if it's possible, central canal decompression, then we actually do a laminoplasty again in order to maintain the motion, to continue to delay the deterioration, the degenerative process. In this 49-year-old female who have myelopathy, and then with a kyphotic lesion, and then the K line is kind of borderline negative, and in this situation, we consider the hybrid surgery. In this, what I mean by that is that we do fusion surgery below and artificial disc replacement on top, and then for the patients. And then the patient with acceptable good outcome. For those people who doesn't want to do anterior surgery or worried about anterior surgery complication, in this case, K9 negative, you can do a laminectomy and fusion, and you can see that the adequate decompression of the posterior spinal cord migration from this particular case in here. And our surgical techniques can be defined as the following reference. This is a case of a patient where there's a significant cord compression, almost 50%, but yet you can see it is a canine neck positive lesion, and therefore, based on the recommendation, we can consider to do a laminoplasty. And you can see that there is an adequate decompression of the spinal cord from the back. And the choice of the laminoplasty that of our choice in our unit, we developed the C3 dome, C7 reverse dome, open door laminoplasty in order to reduce some of the laminoplasty complication has been described in the literature. And you can see the range of motion is reasonably well preserved by using these techniques, and the result have been encouraging. Finally, we will consider a combined surgery especially when the patient has regional and global sagittal deformity with multiple cord compression. This is a patient who basically is 69 years old with multiple compressions, and then with a drop almost like a chin on chest deformity. And then you can see that in this particular situation is rather rigid because of the deformity. Therefore, we do an anterior combined and posterior surgery for that. And you can see that this is what we do. The first stage C3, 4, C4, 5, C5, 6, C6, 7, A, C, D, F, and then using a 0P type of instrument, and then release the soft tissue, and then using a 3-rod technique doing a posterior spinal surgery. And this is before the surgery, and this is after the surgery for the patient to restore the function. Finally, therefore, the consideration to consider anterior surgery versus posterior surgery, one would think about the number of level, more than 3 level, may go posterior, type of pathology is important, the amount of compression is important, regional spinal alignment is important, and global sagittal alignment is important. Of course, you need to think about patient factors and also the surgeon factors as well. So in summary, for me, I would do anterior surgery for patient who has 1 to 2 level or 3 level if it's particularly kyphotic, a significant cord compression. My go-to myelopathy choice for multiple level, 3 or 4 levels, is a C3 dome, C7 reverse dome laminoplasty. I add fusion to the posterior surgery if they are poor sagittal alignment, particularly canine negative patients. So these are some of the indication. And finally, for me to consider anterior and posterior surgery, usually they occurs in multiple level rigid cervical kyphotic deformity with significant cord compression. Thank you very much for your time.
Yeah, thank you. Thank you, Gabriel, for nice talk. Yeah, any questions from the audience?
May I, Professor?
Yeah. Okay, yeah. Rishi?
Thanks, Dr. Gabriel, for the wonderful talk. So I have a question like whenever we have a patient with a single level stenosis, but in the presence of a constitutional canal stenosis where the entire spinal canal is narrowed, so would you still prefer to do an anterior surgery or would you like to go posterior?
Depends on where is the compression, right? And then if the compression is from a single level, and then if it is a developmental stenosis, if the patient is relatively old to a certain extent, so you know the developmental stenosis is pressing on the cord for many times, and if the symptom occurs really quite recently, and then I will consider the anterior surgery just to preserve some more segment first, and then the surgery of choice that I would prefer to do is going to be a anterior fusion surgery. And of course, if the patient is a young developmental problem, and then if the compression again is anterior, and then the patient is young and they want to maintain motion, then in that situation, then artificial disc replacement may be suggested, but this must be followed up by a laminoplasty at the back of the spine to at least discuss to the patient and offer to the patient in that particular situation for developmental stenosis. So this is my current thought process.
Thank you.
Yeah. Can I ask one question? Yeah. So very nice talk, Gabriel. So I have a question. If suppose you have K line which is negative, there is a kyphosis, more than 3 segment. Do you anytime prefer to go first posterior and then wait and later on you go anterior?
Yeah, so if it's a K-line negative and then patients, and then if there's no clearly. And then, so in addition to K-line, I would probably look at the C2, C7 SVA, the global sagittal alignment, and of course, as Professor Yoshi talks about this, the Professor Yuda and Professor Abumi talks about the segmental kyphosis at the 13-degree segmental kyphosis with no causing no changes, or 5-degree segmental kyphosis with causing no changes. So all of this will give rise to whether we need to consider some anterior surgery or maybe posterior surgery with fusion as well. But in summary, is that if it is a K-line negative, that if it is elderly patient, multiple level with developmental stenosis, yes, I would go posterior. If it is a K-line negative patient with a multiple retrodiscal compression rather than a retrovertebral compression, then in that situation, then if it is relatively significant foraminal stenosis, then I would actually do anterior surgery first, because I can look after the foraminal stenosis better in a young patients with only a retrodiscal problem.
In actually long segment compression, even in young patient, what we have found, it is not only that you see the shift of the cord, you make the whole area more safe for your second anterior surgery. So what we have found in many patients, we do just posterior laminoplasty, or you can do even laminectomy and do the instrumentation and create the lordosis. That is one. And if the symptoms persist, mainly in the hand symptoms, usually because hand symptoms, the root has to be decompressed. In those cases, then second sitting, many a time patient doesn't require any surgery, just posterior suffices, he improves. And in remaining persistent hand weakness, we go localize anterior decompression. Yeah, that's what the point.
In this group of mainly retrodiscal problem, and then i.e. the lesion is behind the disc only, that's not behind the vertebral body, significant foraminal stenosis with kyphotic segment, then in young patient, then if possible, I would go for hybrid surgery, some fusion, some artificial disc.
Okay.
Gabriel, yeah, for the combined surgery of the multi-level cervical DCM or OPL patients, we usually combine anterior discectomy, corpectomy fusion, and then laminoplasty or laminectomy fusion. But how do you decide post-surgical option, laminoplasty versus laminectomy fusion?
If it is deformity with a kyphosis, most of the time I would after the anterior surgery I would do is a laminectomy and fusion. Or recently, I mean, there's a trend to move towards laminoplasty and fusion, and then for the posterior choice of fixation. In terms of laminoplasty after anterior surgery, and then again, it's followed the same rule, whether they have a good lordosis or not. If there is, then maybe a motion preserving is still preserved. But if there is a regional deformity, in my practice, most of the time I use a fusion for posterior after the anterior surgery.
Yeah, Gabriel, yeah, last year you and I attended the CSS meeting in Chicago. At that time, I was surprised to see some cervical expert in USA perform anterior 2 or 3 level arthroplasty and then laminoplasty surgery for the multi-level pathologies. How do you think about your opinion that?
I think that's for what there is a proof. Yeah, I think that is basically as you know, our good mentor Professor Dan Ru, and then I think he is developing the concept of that if there is a developmental stenosis, right, and then yet there are some patients still demand on the motion preserving on the neck motion, and he's of the opinion to give them the best choice, and therefore just relieve directly anterior using artificial disc. But that is for the retrodiscal problem. But if it's a retrovertebral problem, and he used the laminoplasty to sort it out. And his philosophy is do it in the same setting. I think in his hand, he can do it very quickly and then with minimal complication. And then for most of us, and then we might need to practice a little bit more first. But certainly this concept is developing for those people who insist on preserving motion. Thank you.
In my last case is that if the myelopathy patients with symptoms very severe, MJ score less than 6 or 7, do you perform the surgery because there is the perceptual symptom improvement is very low because the patient's myelopathy symptom very still MJ score less than 6 or 7, 5 or 6. To perform the surgery for the patients?
Um, yeah, thank you. I mean, although the recovery rate may not be high, and then as you are all familiar with that, I mean, I think that you guys have published a lot, and also in Japan, and then people who are more than 70 years old, the surgery recovery rate is poor, and then Michael Failing's work, if you do the decompression, you may improve on one grade of problem. And in my practice, if the patient wants surgery and then is fit for surgery, I will offer surgery. And then the aim of the surgery, I always tell the patient, is to stop it from getting worse or delay it from getting worse. I don't promise them you will recover, but hopefully it will delay it.
There is a
Professor
question
Park.
from Yoshiharu. Yeah,
Yeah,
there is a
Yeah,
question.
Professor Park. Yes, thank you. Yeah, my question is which posterior anterior is okay, or anterior posterior is okay? So which is better? My thinking is I always do the posterior decompression surgery or fusion, and then the anterior surgery is a second choice. So what do you think of the my thinking, my indication, posterior at first, and then if the patient has the main symptoms and then not recovery well, I will think of the anterior surgery. What do you think about that?
Thank you very much, Yoshi. I hope you're not driving when we're talking to us in the car at the moment. But yeah, I totally agree with you. I have a similar feeling as well. And then especially for those patients, we want to maintain motion. So I will, if the patient is suitable for lameloplasty, I will always go for lameloplasty. And then if posterior first. And then even though with the alignment is not as good as per what we talk about in the literature, and then I will tell them subsequently, if they remain symptomatic, then I will add a single level anterior surgery to alleviate that 60% cord compression at that particular C5-6 level, rather than doing the entire fusion surgery for the spine. Thank you.
Thank you. Yeah, I have some cases. I plan to the second stage surgery from posterior and anterior, but just a posterior surgery, the patient recovered and the patient refused the anterior surgery in this case. So that's why I think the posterior at first might be better. I think.
Absolutely. Or
I
because
definitely-
Professor Yoshi, your surgery is too expensive. They can't afford the anterior surgery.
No. That is not a cost, just a symptom. I mean,
Only joking, only joking.
yeah, thank you. Yeah, thank you.
Yeah, actually, all of you should be agreeing that apart from doing this stage surgery of this, it provides safety. Maybe anterior is not required, and more so, what I strongly feel, when you decompress posteriorly first, you create a space for a safe surgery later on anteriorly, because there is a space. Otherwise, a very narrow canal, thinned out cord, sick cord, and if you are handling anteriorly, and if you anytime you use the hammer and chisel, then patient is gone.
Yeah.
I totally agree with you. And then especially for those cases who are 70% compression, 80% compression, then posterior surgery would be much better. But probably 60 or less than 60, then anterior posterior surgery, I think in most of our hands are reasonably safe.
Yeah.
Okay, yeah, no more questions. Yeah, let's move on to third talk. Yeah, Dr. Sri, yeah, you'll manage it.
Yeah. Thank you very much, Professor Park. Now I would be inviting Dr. Rishi Kanna. He's from India. He's working in Ganga Hospital, a very senior consultant. He's going to deliver his talk on future perspective, biomarkers, then regenerative medicine, AI, and robotics in degenerative cervical myelopathy. Dr. Rishi.
Good morning, friends. Thanks to APSS for this wonderful opportunity to present this topic, Future Perspectives in Degenerative Cervical Myelopathy. Today I'm going to discuss about artificial intelligence, biomarkers, the role of robotics and regenerative medicine in managing cervical myelopathy. Myelopathy is by and large a clinical diagnosis and supported suitably by radiological investigations. So we look for the classical symptoms of numbness and weakness in the hands, stiffness and gait disturbances, and classical signs like hand myelopathic signs and various upper motor neuron signs to diagnose a patient with cervical myelopathy. However, all these observations are subjective in the sense that the experienced clinician can diagnose these in the very early stages of the disease, but an inexperienced and young surgeon may find it difficult. And so if you look at the natural history of cervical myelopathy, most of the patients, they go through a phase of steady decline, which is seen in about 70%. In about 20%, the neurology is fairly maintained over a period of time, but there is a quick decline towards the end. And a small group of patients may have a post-traumatic paralysis. So our aim as surgeons to catch these patients before significant damage to the spinal cord has happened. So can we identify patients who are prone for early worsening? Can we diagnose these patients through a certain screening tool because before significant damage has happened in the spinal cord? And is the cord already damaged even if there are no signal changes we see in the MRI sequences? So where these biomarkers and artificial intelligence can help in the future is we should be able to diagnose the disease earlier before permanent cord damage. We should have a better screening, more objective tool which can avoid subjective clinical failures. We should be able to avoid certain wrong diagnosis, and we should be able to tap on the big potential of big data. And the future robotics and navigation should help us to make our surgeries more precise. So coming to machine learning through for early diagnosis of cervical myelopathy. So hand clumsiness, by and large, we are now diagnosing it by subjective measures based on the surgeon's clinical experience. So in this study, they used a tablet and a machine learning technique to analyze the hand function. So they evaluated 38 patients with cervical myelopathy and 66 volunteers. So all the patients and volunteers were using a stylus pen to draw these different patterns, a circle, a square, as well as a triangle. Based on the multiple writing parameters, they found that models with triangular waveforms were found to be very accurate and had more than 76% sensitivity and specificity to diagnose early cervical myelopathy. And second problem which happens in patients with myelopathy is the gait instability, but in early stages, it requires a lot of experience to diagnose it. So is there a more objective way of evaluating it? So in this study, the authors evaluated 45 patients with cervical myelopathy and compared with 45 asymptomatic healthy volunteers using three-dimensional motion capture system with multiple parameters, almost 63 in different planes. They evaluated the gait patterns and noticed that this technique has a 95% accuracy to predict early cervical myelopathy. How about non-invasive skin testing? So advanced glycation in products which are nothing but sequential non-enzymatic glycation of protein amino groups, which usually accumulate in various tissues with normal aging. But this could be increased in the presence of conditions like arteriosclerosis and diabetes. This can be easily measured with the use of skin autofluorescence technique. So in the study, the authors evaluated 93 cervical myelopathic patients and classified them with low AGE group and high AGE group. They noted that higher AGE scores were associated with severe DCM. So in the future, this could be one of the useful non-invasive biomarkers to diagnose patients with early myelopathy. Coming to imaging techniques, diffusion tensor imaging, it is a type of MRI which can evaluate the movement of fluid within the neurons. This can also be quantified using the parameters like fractional anisotropy and apparent diffusion coefficient. So if this flow is interrupted due to disease, that's cervical myelopathy, this can be assessed even before MRI signal changes. So we evaluated patients with cervical myelopathy using DTI. 35 patients were compared with 40 volunteers. We measured multiple parameters and the level of the cervical cord compression. So what we noticed was all the diffusion parameters were significantly altered in patients with cervical myelopathy. And post-operatively, we performed DTA again at 6 months duration. We noted that patients with neurological improvement, about 20 had neurological improvement, and all the parameters showed subsequent improvement in the post-operative diffusion tensor in the imaging. 5 patients did not have the expected neurological improvement, and when we performed DTA, we noticed that the values did not improve at all. So in patients who did not improve, the indices worsened further. Magnetic resonance spectroscopy is another MRI-based technique which can actually measure the concentration of metabolites in the spinal cord tissue non-invasively. So we recently performed a prospective observational study to analyze the utility of MRI-based metabolites in the detection of early cervical myelopathy. So the study population had 20 volunteers and 69 myelopathic patients. So we noted that several MRS metabolites, specifically the glial cell specific metabolites, choline, creatine, and myosin inoside, with respect to the N-acetyl aspartate, had a good correlation in early identification of DCM patients. Can we combine these different MRI modalities and come with a better diagnosis? Yes, this is called as a multiparametric MRI, where the cross-sectional area of the spinal cord, diffusion tensor parameters, magnetization transfer ratio, and the T2 weighted white matter and gray matter signal intensity ratio can also be combined together. And in the study, the authors noted that when we applied this multiparametric MRI, they were able to detect subclinical tissue injury even before the onset of neurological symptoms and signs. So this could be helpful in early diagnosis and screening of patients. Invasive testing like CSF analysis has also been performed. So in this study, the authors compared the 33 myelopathic patients with 7 radiculopathy patients. Intraoperatively, they evaluated the CSF for different biomarkers. They noted that all these neurofilament values were significantly higher in the cervical myelopathy group. So can we diagnose cervical myelopathy early before significant damage? Yes, different parameters are holding a good hope for us. So hand signs and gait imbalance using machine learning, skin testing using advanced glycated end products, diffusion tensor imaging, MR spectroscopy, and multiparametric MRI could be very helpful in the future. Coming to the management, what the future holds for us. So if in the future, we should be moving more towards non-surgical drug-based treatment. We should be able to prevent demyelination in the area where the cord has been compressed, promote regeneration of the injured neurons. So aim is to avoid surgeries. And even when we are performing surgeries, we should be using neuroprotective and neurorestorative therapies to enhance the surgical outcomes. So neuroprotection basically means preventing further cell death. So riluzole, a benzodiazole sodium channel blocker, has been evaluated in patients with cervical cord injury and cervical myelopathy. It has shown some promise. In one of these recent randomized control trial, the authors noted that in cervical myelopathy, it is good reducing the post-operative pain, but there were no significant differences in the MJE score. Neuroregeneration should replace the lost tissue damaged by the cervical cord compression. But one big problem with the cervical cord is its limited regenerative capacity. But one drug called ibudilast, which is a phosphodiesterase inhibitor, has been evaluated and studied experimentally in several animal and human studies, but still it is under experimental stage and not translated to clinical efficacy. Stem cells have also been tried, but again, not to the level of clinical efficacy. Neuromodulation in areas where the cord has already been damaged, there should be a scope for altering the neural activity through targeted delivery of an external electrical or a chemical stimulus. So DBS, spinal cord stimulation, repetitive transcranial magnetic stimulation, functional electrical stimulation, different techniques have been tried in cervical myelopathy, but still they are all currently experimental. What about big data? Big data is basically the availability of large data across multiple centers across the world. They should be integrated. We should be able to connect all the imaging systems where multiple MRIs, X-rays, and CT scans of patients with DCM can be evaluated. Patient-enabled post-operative functional outcome scores can be integrated, and such a huge volume of data could be easily tapped by machine learning and neural networks, and better outcomes and screening tools can be devised by artificial. Coming to robotics, currently we are using it to insert pedicle screws deftly without injuring the spinal cord and the vertebral artery. But in the future, robotics and navigation should be helpful to plan osteotomies, safe execution of surgeries in planning the laminectomy location and depth, and resection of the OPLL without placing the spinal cord at risk. So in conclusion, the future looks promising. Multiple AI tools for diagnostics, clinical outcome production, surgical assessment, and decision supporting should be playing a big role. And based on screening, we should be able to identify high-risk patients. We can explain them to avoid contact sports and participation in army and police forces. Preclinical diagnosis could be very helpful. Early medical management, neuroprotection without a surgical intervention should be possible. And best surgical practices will be evaluated based on AI data. And the neuromodulation and neuroregeneration could also be helpful in patients who have developed spinal cord damage. So thank you very much, APA and the listeners, for this wonderful opportunity. Thank you very much.
Thank you very much, Dr. Rishi, for a wonderful talk. I think all non-invasive investigation which you told, I think these are very, very important. I think a day will come when this will become a type of standard of care in the management of, cervical myelopathy of the degenerative etiology. Is there any question from our faculties?
Maybe I have a questions.
Please,
And then,
please.
yeah, Rishi, thank you so much for the wonderful presentation on the different techniques. Tell us what is with all the listed improvement and the futures, what is the one that's currently that we can apply now, tomorrow in our clinics?
Among these things, the only thing where we had practical experience on a larger scale is the diffusion tensor imaging. So almost for 7 to 10 years, we have been working on this. On an individual patient, I won't say that it has given clear-cut results in either predicting the outcomes or making a decision whether to do a immediate surgery or we can wait and watch, or to decide the type of approach, whether we should do an anterior surgery or a posterior surgery. But in large pulled up data, we will be able to identify certain parameters. The FA and ADC values were able to guide us that even though there are very little signal changes in the cord in the conventional MRI, DTA is able to predict certain diffusion parameter alteration, which will indicate that there is some ongoing damage in the spinal cord. So in those patients, we try to convince them for a surgical intervention. Whereas rest of these things, this machine learning, artificial intelligence, I think they are at a very primitive and infantile stage. It will take some time for it to reach fruition and practical application on a day-to-day basis.
Yeah, Dr. Yoshiharu.
Thank you very much, Rishi. I really appreciate your great talk. I'm wondering we can make the medications relation of cervical myelopathy not about the steroid. So what do you think of the future perspective for the medication to treat a patient with myelopathy?
That would be a miracle, Professor Kawaguchi, like how we initially in the past used to treat acid peptic disease with complex surgeries, and then once these proton pump inhibitors and medications for this H. pylori came up, we are able to treat all these acid peptic diseases with medications only. Nobody performs the surgeries these days. Like that, one day will come when we are able to treat cervical myelopathy with series of tablets for 6 months, and then the patient becomes completely all right. But at present, there are only two medications. One is the Rolizole and another one is the Ibudilast, but both are at a very preclinical stage. They are not able to help patients on a practical situation.
Yeah, Rishi.
Yeah, I hope to have the good medication for the treatment of the cervical myelopathy. Thank you very much.
Thank you.
Rishi, though you answered this question, but what I feel, even the acid peptic disease, earlier we were not treating the cause. We were doing all those vagotomy
Yes,
and all those
we
things.
got.
But here, the etiology is compression. So I think even the medication, regenerative medicine, yes, it can work for some time, but
Yes.
we will not be treating the cause of the compression.
Yes.
So compression, the etiology, so it appears, at least today, it appears that
Yes.
whether it's going to, you have a question, whether it's going to work or not.
Yes, sir. There are two components to it, sir. One, the disc getting degenerated, evolving into a disc prolapse or a osteophyte causing compression.
Yeah.
And second is the compression over the spinal cord, which slowly results in a spinal cord dysfunction. So I personally believe that over a period of time, we'll be able to crack the reason why a disc degenerates.
Yeah.
Either by genomic intervention or by skipping the RNAs or by treating the possible bacteria which is causing the degeneration, so that we'll be able to treat that problem of degeneration. So once degeneration we are able to avoid in at least in young patients, there may come a day where we will be able to treat these patients with some vaccine or something to avoid a surgery in the future. I'm telling like a prophetic statement.
Yeah. Okay. Is there any other question in the faculty?
Rishi? Yeah, Rishi.
Yeah, Park. Yeah, please.
Yeah, in Japan nowadays, clinical trial of iPS stem cell therapy for spinal cord injury is being performed, and then Professor Masai Nakamura reported some prelim results of very promising. Also, do you think that also stem cell therapy for DCM is also can be promising, or now is there any clinical trial for stem cell therapy in DCM treatment?
Professor, is it through stem cells?
Yeah.
Yeah, again, like we had tried a lot of stem cell treatment for patients with acute spinal cord injury, but we are not able to overcome the basic problem, because here stem cells have to take care of the myelin sheath, but the actual cell is located somewhere in the brain cortex. So still for myelopathy, stem cells have not reached for only its animal stages, only it's helpful.
Oh.
Is there any other question for the faculty? Because in chat box, there is no question from the audience. So should we move to the case presentation, which Dr. Jin Sup Yeom is going to present? I invite him to present his case, please. Yeah.
Oh, can you see my slide?
Yes, very much.
Okay, I'm sorry that this case is not related with degenerative cervical cord compression. The patient is an orthopedic surgeon. He had 2 previous C1, C2 surgeries by another surgeon. The same surgeon did the 2 previous operations. When he came to me, his chief complaint was persistent neck pain, and he complained of intermittent clumsy hand, but I'm not sure whether it was from the cord compression or not, because the physical exam was all normal. This X-ray is taken at 4 days after the primary surgery. It was done in 2011. This is an old case. You can see orthodontoidium here. And this X-ray was taken 2 months later. You can see there was a motion here. So there was non-union. And it's not non-union because it was fractured. Both pedicle screw was fractured here. And looking at the initial X-ray, the screw looked a little bit bent. And I think the core diameter of the screws were too small. So it was fractured here. And we can see that there is no bone graft here. The initial surgeon used just DBM, the patient told me. So several months later, the initial surgeon did second operation, and he used this kind of screws at C2. I've never seen this trajectory, but actually he used this, and there was a loosening of the screws here, and you can see the broken pedicle screws. And again, there was no bone graft. At this time, the patient told me that the surgeon used DBM plus small amount of autocancerous chips, but it was resolved. This is a 3D CTA, and this is a screws. And looking at the axial view, the right screw was a little bit too shallow, and left screw was a little bit too deep, like this and like this. And at C2, you can see the pedicle screws were broken here, and on the right side broken here. And new screws, something like laminar screws, they were loosened on both sides. And there was a mild violation of right C2 transverse foramen here, but it was not a big problem. And this is broken screw, and this is new screw on the left side, and you can see the loosening around the screws. And what is this? This is CT angiography, and this is called persistent first intersegmental artery. In presence of this artery, intra-articular fusion of C1, C2 facet joint may be dangerous. You may rupture this while you are doing this. MRI was relatively okay. There was minimal cord compression, even with orthodontoideal in this position. So what do you do for this orthopedic surgeon? OC3 fusion or other options? Okay.
Yeah, actually, there are two options in this case. One is that, though you told that there is anomalous vertebral artery, but if you just glide, you just go to the back slide, which you had just now shown.
This one?
No, after this. Yeah. So please stop. So
This
no.
one?
Yeah. Bas, stop here. So the vertebral artery is going like this. So here, if we just glide your small periosteum over the pedicle of C2, you directly land up into C1, C2 joint. So there, actually, bone graft can be put, both the side it can be put, and if you are not able to take out the screw, then Galli's fixation and fusion can be done. Instead of Galli's, the Brooks fixation will be better, because Brooks fixation, it holds the segment so nicely that it doesn't allow the rotation. So Brooks fixation is better. Good amount of graft should be put between C1 and C2. Even the posterior fusion can work well if it is a Brooks fixation. Or the second option, if you are not able to take out implant is broken, you are not able to do anything, in that case, or vertebral artery anomalies are there, there are cases where the anterior fusion has been done. Anteriorly, the graft has been put between the joint, and the short segment fixation can be done anteriorly. But that is a little morbid procedure as compared to the simple Brooks fixation. Fusion is very important. Meticulous fusion with proper iliac crest graft should be done in this case. And I think that will work for this doctor. Any other opinion from the house?
There was a...
May.
Let me talk first.
Yeah.
There was a bone stock deficiency here at C1, like this, and here at C2. So wiring or cabling might not be strong enough. And he had 2 previous operations, and we have to worry about non-union. Maybe the myelopathy symptom, it was not clear. He was an orthopedic surgeon, so he talked about the hand clumsiness while he was doing operation, but it was not clear to me, and his main symptom was just neck pain. So we have to get fusion at a third operation, I believe.
Yeah, instability is the cause of his pain, and 2 times surgery has been done. The fusion not occurred because proper fixation was not there from the beginning only. So even the posterior cortex, the posterior element is quite hard and good quality. I think the purchase will be still there even with that. Or maybe if you're finding that the screw is stuck there, you can just leave it. And I think we can concentrate posterior, and I think it will work in this patient. Second option I told you, if one side screw is there but it is loose, you can take it out and put the wider diameter screw. If the track is all right, if it is not perforating the laterally, then yes, you should avoid that. But still, this can be managed.
This translaminar screw can be attempted at C2 level because the laminar screw that has been tried is in the wrong direction. So it should start from one side and then proceed to the other side. And for C1, we can remove those screws and put a bigger diameter screws. And along with C2, we can insert the C3 lateral mass screws or the pedicle screws that will add strength through the construct. And as you told, sir, we have to prepare the posterior elements and put a lot of autograft from the iliac crest. So the aim is to attain a good fusion.
Yeah.
If we put C2 laminar screw in this direction, this cortex was broken already. Can it be strong enough?
Yeah, it should start usually from the opposite side and goes to the other direction along the surface of the lamina, isn't it, Professor? So here I'm not sure. This is a different type of screw which we have not seen before.
Mm.
And as Dr. Rishi pointed out, even if you take out a screw, at least one side, you pass from the right, it will go to left, and it will definitely have a better hold. Actually, the lamina of C2 is so good that you can put 2 screws very easily. So I think Professor Jin should break the silence now, and he should tell what he has done.
So no other opinion?
Yeah, no other opinion. I think in chat box also, there is no question. So suspense, remove this suspense now.
Okay. So looking at on the left screw, we can find it easily.
Yeah.
So I decided to remove it using a hollow reamer. And on the right side, the screw was fortunately too low. So I decided to, and it was deep inside the bone. So I decided not to remove this and just add one pedicle screw above this screw. And as I told you before, I was not happy with the C1 screws, which had small core diameter. So if I put pedicle screws here and use the original C1 screw, they may be fractured again. So I decided to remove those C1 screws. And I did this. This is a cross link. And you can see 4 mini screws, including this one. So this is what I did. I changed removed the original screw and changed it with thicker screw, 4 millimeter screws, and I did bicorical fixation at C1. And at C2 is near bicorical, even though it was not real bicorical. And on this side, the broken screw was not removed, and I used a new screw. And on this side, I removed the broken screw with hollow reamer and added new, at the same trajectory, I inserted a new screw. And you can see the mini screws. This is iliac bone graft on both sides. And so I used 4 mini screws, including this one. And cancerous bone graft was placed in this area and also in this area. So this is a broken screw, this is new screw. And I did intra-auricular fusion on both sides. We can do intra-auricular fusion with, even in cases with persistent first intersegmental artery. If we do it meticulously. And this photo was actually captured from video. I was worried about Zoom presentation, so I just captured. This is green sticked, and 2 fragments actually, and 4 minuscules. So these are corticocancellous plates. And after cross-linking, I added a lot of matchsticks and cancellous strips. So this is post 1 year CT scan. You can see the satisfactory bone union here, like this satisfactory fusion mass here and here. And 1 year satisfactory fusion mass here and here. And 5 year dynamic radiograph shows a solid union. That's all.
Yeah, excellent, excellent. Yeah, Dr. Yoshiharu, yeah, you have a question?
Yeah, thank you very much. Just a comment. I think previous first doctor should not do the operation because he doesn't know the concept of the cervical fusion. So I think the first operation is necessary to fail because there is no fusion mass. So that operation Professor Yeom did is very nice. But the first surgery, the first doctor should not do the operation. He must understand the concept of the surgery. Thank you. That is my comment.
Any other question from the faculty?
I have a question.
Please.
Thanks, Jin Sup, for the excellent case. And then, as always, it's amazing techniques that you have, and then the steady hands and the fine instrument. As you always say, C1, C2 fixation is your hobbies, and then we can see that you are expert in this particular area. I want to in our hands, and then sometimes, and then to achieve the good fusion rate without the using the islet crest graft. I mean, obviously we use islet crest graft sometimes, but if we don't, and then we have been using some off-label small dose of BMP with a cortical bone graft. It seems to be working okay for us in that aspect. And then if we cannot remove the screw, then I think initially I might actually follow what Rishi, Dr. Rishi have recommended. I may try a translaminate screw, and then together with the BMP, that might help, and then immobilize them for a while. The question I really have is that, but I mean, ideally, if we can do what you have done, which is probably the strongest fixation. The question I have is that in the C1, C2, there are some recent report and then suggesting the post-operative pain, apart from the obvious pseudoarthrosis at the moment, it might sometimes be because of the loss of C1, C2 lordosis, or the C2 slope become kyphotic, or sometimes in this particular case, apart from the obvious pseudoarthrosis, the rod is too long and is impinging on the occipital area. What is your experience on this aspect in terms of restoring the C2 slope, restoring the C1, C2 lordosis in fusion, and also in this type of situation? I understand in this particular case is clearly pseudoarthrosis. Thank you.
About the angle, this is just one level fusion. So angle, in most cases, inadequate angle, I believe they do not cause pain in most patients. But if the rod is long, particularly above C1 screw, and if you use when you use the rod, we cut the rod usually in most cases. If the sharp cut end is cranial and the rod is too long, it may invade the occiput and it may cause pain. So I always use the smooth end cranially and always fix C1 screw cap first to avoid that problem.
Yeah. I actually, the question to Professor Gabriel. Actually, we always see the clivus canal angle and without the Wackenham line, actually. So this C1, C2 alignment along with the clivus is extremely important. So clivus canal angle, cervicomedullary angle is important. And even if your dens is it is tilted posteriorly, it can cause impingement. So I think these radiological parameters are extremely important, which usually gives a very good result if one pay attention while doing. So it should be the both lateral pillars should be actually locked and fused in the extension. So that is important. It should not go into kyphosis because the size and weight of the head is significant and there are always chance of toppling. So, and fusion has to be good to have a very long lasting good result, as Professor Jin has done a nice correction of the thing. So if there is no question, I will go ahead and I invite Dr. Dong Ho Lee to play his video. Yeah, please go ahead.
Good afternoon, friends. I'm really excited to be here with many active young spine surgeons like you at this webinar. First of all, we need to think about this. When should surgeons consider anterior decompression for OPLR patients? First, we should look at the corneal occupying ratio. According to Iwasaki's study, in the cases that the corneal occupying ratio more than 60%, post-op neurologic outcome is much better after anterior decompression and fusion than after conventional laminoplasty. But in their series, complications following anterior approach is still high. Graft complication occurred in 15%, so additional surgery was necessary in 22%. Another indication of anterior decompression is severe kyphosis. Severe kyphosis indicates a sufficient posterior shift of the spinal cord, and neurologic improvement could not be obtained after posterior decompression surgery. So Koda's and Uchida's studies commonly told that pre-op kyphosis more than 10 degrees is one of the contraindications of laminoplasty. In that case, surgeons need to consider two options. Those are anterior decompression or posterior correction of kyphosis. Is there any parameter to see the size of mass as well as kyphosis at the same time? That is the K-line. The larger pre-op kyphosis is, or the more OPLR mass posteriorly protrudes, the more evidently K-line would change from positive to negative. In this situation, one of the solutions to achieve better outcomes is anterior decompression. Of course, during this procedure, we could achieve better sagittal alignment, that is, good lordosis by alteration of K-line. Then, why do many surgeons hesitate to do anterior decompression in severe OPLR patients? That is because anterior decompression surgery for OPLR is technically demanding and associated with a higher incidence of perioperative complications, including neurologic deterioration, dural tear, CSF leak, implant dislodgement, or pseudoassociates as well. To prevent dural tear in the case with severe dural adhesion of OPLR mass, anterior floating technique was developed. But to do this, much wider and much more level corpectomy is necessary. That could cause graft-related complications. Another problem is that surgeons could make additional cord injury. Although it was done successfully in some cases, still the thin mass remains inside spinal canal, compressing the spinal cord. So we came up with this idea. Why should we remove the OPLR masses directly? Instead, How about pulling out the masses anteriorly? Then surgeons would not need to directly manipulate the operculum mass at all. This technique had been developed myself in 2012 and published first in 2018. It was named vertebral body sliding osteotomy. If it is a little complicated to remember, then just remember it as sliding osteotomy. This is a basic concept of sliding osteotomy. We expand the stenotic canal by anterior translation of involved vertebral bodies as well as ossified masses. After multi-level discectomy, the vertebral bodies are longitudinally cut on both sides with drill. The freely movable bodies are anteriorly translated along with ossified masses. Translated bodies are initially fixed with tight cage insertion, then anteriorly protruding part is shaved down and fixed to the metal plate with screws finally. For smoother translation, the upper and lower level disc and PLL should be resected completely. To make more lordosis, intervening level operculum mass could be drilled out very thin for green stick fracture effect. Let's take a close look at the surgical procedures. Please enjoy the video. After removing the discs at the targeted levels in a routine manner, posterior longitudinal ligament is excised at the uppermost and lowermost levels to mobilize the vertebral bodies in between. Next, targeted site of bone resection is marked using a burr. By using a 2 to 3 mm high-speed burr, two parallel longitudinal slits are made along the medial borders of the uncinate processes. Uncinate process is a landmark in this procedure, and lateral slits should be kept medial to the uncinate process, since making slits lateral to uncinate process would risk vertebral artery. Hemostasis is achieved by applying bone wax and using additional hemostatic agents. After making the lateral slits and vertebral bodies become movable. The vertebral bodies are grasped using Ellis forceps. By manipulating Ellis forceps, surgeons can translate the vertebral body anteriorly in the desired amount. Interbody spacers are inserted while maintaining the vertebral bodies in a desired position. First, the allograft is usually inserted at the middle level, followed by uppermost and lowermost levels. After inserting the bone graft, the Caspar retractors are released to apply slight compression force to the operated segments. This would hold the operated segments in the desired position. Before applying anterior cervical plate, the anteriorly protruded portion of the vertebral bodies is removed by using burr and pituitary forceps. Finally, the anterior plate is applied. While inserting screws at the mobilized level, the screw holes should be tapped. Since inserting the screws to untapped mobilized level would push the vertebral bodies posteriorly, and it would result in a loss of decompression. Additional anterior translation of the vertebral bodies can be achieved while tightening the screws by the leg screw effect. To investigate the efficacy and safety of this technique, we compare the outcomes of VBSO versus those of corpectomy. In VBSO group, operation time is shorter and blood loss is less significantly. There is no neurologic deterioration, CSF leak, and graft migration associated with VBSO. Only 2 cases showed shoulder associes, but no additional surgery was required. Neurologic outcomes were similar between 2 groups. Corneal widening and post-op lordosis were significantly better in VBSO than ACCF group. This is the result of another study. Based on multi-level ACDF, VBSO improves the cervical lordosis more than corpectomy in patients with kyphosis. Also, preserved vertebral bodies in VBSO provide structural support to prevent graft subsidence. This is another question. Could the sliding osteotomy be utilized for the decompression of eccentrically located OPLN mass? So, we have developed a brand new technique, so-called vertebral body rotational osteotomy, which is a modification of vertebral body sliding osteotomy. It is indicated for laterally deviated ossified mass to achieve further decompression. After making 2 lateral slits at the base of the uncinate processes, anterior translation of the vertebral body is made along with OPLN mass with gentle traction as in the VBSO procedure. At this point, central mobile fragment is rotated additionally until the lateral slits are closed to achieve further decompression. This slight rotation allows more efficient cord decompression for eccentrically protruded OPLN masses, while minimizing bone loss and preserving bone contact. Then, what is the best indication of sliding osteotomy? It is very similar to that of corpectomy. We introduce a very helpful algorithmic roadmap for surgical decision-making of cervical myelopathy in Asian Spine Journal in 2023. According to this algorithm, the best indication of sliding osteotomy is K-line negative myelopathy patients with or without semi-rigid or rigid kyphosis involving 3 or less segments. Next, how can we evaluate the satisfactory decompression after anterior cervical procedures? To the best of our knowledge, the corneal occupying ratio has been the standard parameter for evaluating the adequacy of decompression. However, if the ocular lesion is very large, or the vertebral body is not sufficiently translated anteriorly, incomplete corneal widening may still occur even after VBSO. This raises the question: does the residual ocular mass truly predict unfavorable urologic outcomes? To address this, we compare postoperative outcomes between patients with complete versus incomplete corneal widening as defined by the corneal occupying ratio. As expected, incomplete corneal widening was more frequently observed in patients with a higher pre-op corneal occupying ratio. Interestingly, however, our results showed no significant differences in either the final JOA score or the JOA recovery rate between the complete and incomplete corneal widening groups. These findings suggest that the corneal occupying ratio may not be a reliable radiologic parameter for predicting post-op neurologic outcomes. Then what could be a better alternative? This led us to develop a new method, which is called the V-line. The V-line is drawn on a plain lateral X-ray in the neutral position. This line connects the lowest point on the posterior margin of the vertebral body, immediately above the osteotomy site, to the highest point on the posterior margin, immediately below it. The V-line classification was V-line negative if the post-op pathologic lesion contacted the line, and V-line positive if it didn't. The V-line positive group demonstrated significantly higher final JOA scores, greater JOA recovery rates, and superior post-op C27 and segmental lordosis compared to the V-line negative group. In contrast, classification based on post-op corneal occupying ratio showed differences only in JOA recovery rate, with no significant differences in final JOA score or cervical alignment. These findings suggest that the V-line is a more reliable radiology parameter for predicting favorable neurologic outcomes. This is a myelopathy patient caused by a huge operant mass involving two vertebral bodies. During or after sliding osteotomy, adequate neural decompression and cervical lordosis can be readily confirmed in real time by drawing the V-line on intra-op Shyam images, as well as on immediate post-op X-rays, CT, and MRI. This convenient and intuitive assessment is not achievable through conventional measurement of the corneal occupying ratio. In summary, sliding osteotomy could be a safer and easier anterior cervical decompression technique than corpectomy. This technique guarantees less complications as well as better post-op lordosis. The best indication of VVSO is K-line negative myelopathy involving 3 or less levels. To evaluate the sufficient anterior decompression, the V-line is a more reliable and practical parameter than corneal occupying ratio. Thank you.
Excellent talk, Dr. Lee. Any question from the faculty, please?
Yep.
Yeah, Yoshiharu, please.
Yeah, thank you. Yes. Thank you very much, Don Henry. Very, very excellent procedure. I enjoyed. My question is the indication. If the patient has a continuous type of OPLL from C2 to C7, is it possible to do this kind of surgery? This is my first question.
So thank you for a nice question, Professor Kawaguchi. So the continuous type OPLL is not a good indication for this procedure. So as I told you during my presentation, the ideal indication is the very huge OPLL mass involving 3 or less disc segments. If we do long-level anterior approach surgery, anterior surgery, we can have a lot of complications such as shoulder arthrosis, the dislodgement of graft, and metal failure, something like that. So I don't like to recommend this procedure for the long-level OPLL mass, particularly in the continuous type OPLL. We cannot disconnect the OPLL mass easily. So in those cases, I would like to recommend the posterior surgery or AP combined surgery.
Thank you very much. My second question is, what kind of material do you put the intervertebral disc space? You remove the intervertebral disc space at first, and then you put some material, maybe the bone graft in the disc space. What kind of material do you insert the intervertebral disc space?
So we can utilize any kinds of graft material such as allograft. I usually use allograft, but we can use PEEK cage and autograft as well. So particularly if we use the PEEK cage with the spikes, we can make initial stability just after inserting the cages. So I think that it could be better. It could be better to use the PEEK cage with some spikes.
Okay, the surgical procedure. You first put in the PEEK cage into the intervertebral space before sliding or after sliding. Which is better for you?
After cutting the lateral slits bilaterally, we can see the central fragment plot spontaneously because of intradural pressure. Actually, intradural pressure is considerable. It can push the central fragment anteriorly. So if we see the central fragment moves spontaneously, just hold the central fragments with Alice forceps, then we can control the fragments very well, as much as we want. Then put the graft to the intervening disc level first, and squeeze the Alice forceps together. Then we can control the mobile fragment with the one hand, and then we can put the graft into the lowermost and uppermost level and release the Caspary trachea again. Then it makes a very good stability, initial stability. But it is not that firm, but it is enough to maintain the central fragments not to move backward.
Thank you very much.
Yeah, Gabriel, please.
Hey, thanks very much, Dongho, for the excellent talk as usual, and wonderful technique. It's just when I'm looking at your wonderful animations, you can see that the animation is getting really nice. The spinal cord is, I mean, the vertebral body is being brought forward, and the OPL is being brought forward, and it just occurs to me, as it brought forward, you take away the excessive anterior portion of the vertebral body to put the plate down. Is there a certain size of the OPLL that you cannot do that? Because most of the cages that we have, the smallest one, maybe the depth is about 12 millimeter. So there might be a certain type of OPLL size that if you pull so much, then the vertebrae on top and below become very thin. So is there, in your experience, what is the limit in terms of the size of the OPLL? You can pull it up, but yet achieve a good successful fusion above and below the OPLL.
So that is very important point. So at the beginning, I started this procedure. At the time, I thought that we could translate the central fragment very much, but actually it was impossible. We just cut the central band of PLA at the uppermost and lowermost level, but still there are very thin OPL layer remained. So if we try to translate the central fragment as much as the thickness of the OPL mass, it is impossible. So that is why we remained some protruding mass inside the spinal canal even after the VBSO. But we found that just a small amount of remaining mass doesn't make any neurologic symptom. So that is why we developed the brand new parameter to predict the neurological outcomes after previous. Even though the small amount of OPR mass is still remained inside the cornea, if we get a considerable amount of translation, this technique could move the OPR mass forward very much. So it make it the OPL detached from the spinal cord and dura. So the limitation of the amount of translation, even after the translation, we still have a very large contact surface between the disc space. We can put the very large size of cages into the disc space. So we didn't find any differences in terms of fusion rate between previous group versus conventional corpectomy group. Additionally, we put the bone graft into the lateral sleeve more. So we believe that they could accelerate the fusion along the disc space. So we reported some papers to show the previous group show rapid bone fusion after surgery. Thank you.
Any other question from the faculties? But there is no question in the chat box. Very nice presentation. I have one question. Usually we have double cord sign when there is a mass, OPL mass, quite adherent, in fact gone into dura. Dura surface is also ossified. In those cases, we do expect some traction, 3 segment you are pulling. So you did not notice any dural, traction, maybe root traction, or though you mentioned that there was no problem of the CSF leak or any neural deterioration. But seeing the amount of shift you have done, we always have that fear in the mind.
Yes, that is very good question. So if the patient has a very severe adhesion between dura and OPR mass, the vigorous translation would make the dural tear. So we are worried about that at the beginning of this procedure. But so we found that actually severe adhesion between dura and OPR mass is a better indication of this procedure. As you know, if the OPR mass has the double layer sign, between the double bony layer, there is a cartilage portion in between. So if we translate the central fragment, all the mass grabs the dura and move it together. So it is very helpful to decompress the intradural pressure. So actually, and nowadays we think that it is the best indication of this procedure.
Did you
yes?
Did you use angled ball tip probe to separate it anytime?
No. And actually, we have experienced 2 cases, 5 cases of C5 palsy. As you told, after the translation of the central fragment, it holds the dura mater and move together sometimes it causes the overtraction of the C5 roots. So that is one of the rare complications associated with this procedure. So we have experienced C5 palsy in 4.6% of patients with this pain.
Could you notice it intraoperative in neuromonitor, or it happened later on that you realize there is a palsy now?
For every single case of myelopathy, I do intraoperative neuromonitoring, but we are checking the change of waves every time, but fortunately we haven't never experienced any experiences showing the change of waves.
Now, my question is that, some of your case you had C5 palsy. So could you notice during the procedure that now there is a problem in the C5 myotome?
No, I don't think so. But the neurophysicians didn't notify me.
Okay.
They found any abnormalities.
Okay, nice. Any
Thank
other
you.
question from the faculties? There is no question in the chat box. So thank you very much. Now I hand over the proceeding to Dr. Shinji for his closing remarks. Is Dr.
Okay.
Park, he wants to speak something? Professor Park?
No, thank you for a minute. Thank you.
Okay. So yeah, Dr. Shinji, please give your closing remarks.
Okay, thank you. Thank you all. As we conclude today's session of the APSS second basic spine webinar, I would like to take a moment to reflect on what has been truly insightful and enriching program. The presentation we heard today offered a comprehensive view of DCM from its historical background and the current treatment and diagnosis and evaluation, and to the exciting prospects for the future. So these talks have greatly enhanced our understanding of where we stand today in DCM. And so I would like to extend my sincere appreciation to all the speakers for their excellent presentation, and to our moderators, Professor Shrivastava and J.B. Park, for guiding the great discussion so effectively. And also my special thanks also go to the APSS secretaries and also TV for their technical support. And finally, thank you to all the attendees for joining us from the AP region and beyond. Your continued engagement is what drives the mission of APSS forward. So I look forward to seeing all of you again in the future webinars or the APSS Congress. So thank you once again and have a great evening.
Thank you.
Thank you.
Bye.
Thank you. Thank you. Bye. Bye. Thank you. Thank you very
Thank
much.
you very much.
Thank you.
Thank you
Bye-bye.
so much.
Thank you. Yeah, thanks. Thanks a lot. So we'll be leaving. Thank you.